so much, Tony, and thanks to the organizers for having me today, and thanks for coming and sitting in the room today. I know we have several people watching this online as well, so it's great to have an audience from different angles. So today I'm going to present to you how we've scaled up mHealth in Botswana, and I'm going to talk to you a little bit about the roots of the project and then go through the project and how we've made this a sustainable project in Botswana. So it started with teledermatology in the developing world. So let me tell you a little bit about what telemedicine is, and specifically teledermatology. So telemedicine is the practice of medicine at a distance. So when the patient and the practitioner are not in the same place and they're using technology, specifically mobile phones or the internet, to transmit the data to each other to practice medicine. And we use this technology in places where there's inadequate access to care. We use it here in the U.S. where patients may be in rural settings, they may not be able to get to the doctor, but we definitely use it in the developing world where there's inadequate access to specialists. And we started using telemedicine in sub-Saharan Africa specifically because there's a severe lack of specialists there. There may be primary care doctors or healthcare workers, but there's entire countries where there aren't dermatologists. And so you can imagine that, especially in the heart of the HIV epidemic, patients had severe and still have severe skin problems that may even be an indication of how their HIV is doing, and no one knew what these skin conditions were. And so telemedicine was very helpful to help those practitioners know what these skin diseases were. And when we got to sub-Saharan Africa to start having relationships with those primary care doctors, set up these telemedicine networks, we realized that physical internet connections were really lagging behind the widespread scale-up of cell phone networks. And this happened probably around 2008 or 9 when we were trying to scale up with computers and internet and use our internet-based telemedicine. We realized I could get my email on my BlackBerry in the middle of Botswana in the desert, and the cell phone networks were incredible. And so cell phone networks were leapfrogging over physical internet connections. So we started developing this field of mobile or cellular phone-based telemedicine. So, like I said, we started with internet-based teledermatology, and this is what my website looks like that I developed in about 2007 when I first started going there. I partnered with the Baylor Pediatric International AIDS Network. They provide pediatric AIDS care throughout Africa. They have clinics throughout they're actually the Baylor International Pediatric AIDS Initiative, I misspoke. They have clinics throughout Africa. I met this man, Stephen Kadu, who's a Ugandan man who lives in Austria, and he was trying to do a similar thing in Uganda. And together we made this internet site, and through the years we've kept up with technology. It now has an iPhone app, which is very active in Uganda and other places as well. So initially we scaled this up in several countries, but there were countries like Swaziland and Lesotho that still had dial-up internet. So we had to create this internet site to operate on dial-up internet. So it can only have about 3 pages that you would go through, or else it would drop you before you got to send the case. You had to make the pictures very small. You can't really upload a 5 megabyte picture over dial-up. But over the years, it's still been very successful. We've scaled up in about 13 countries. Since 2007, we've handled 1,500 consults. We recently did a review paper on all of these consults. And we've also done an interesting thing where there's sometimes consults that you just can't answer without a biopsy, and I'll show you an example of that. I could do a lot with teledermatology. This is how we learn as residents, by looking at pictures and making diagnoses. But for example, there's some tumors on the skin that I can't tell you what it is without looking at it under a microscope. So when we are really stuck and it's from a patient that is from a country where they don't have the ability to process a biopsy, we've actually developed understandings where they can send a biopsy to me and I could process the tissue. We also did a survey of these countries to determine what countries don't have access to histology so that we knew which teledermatology cases we needed to actually have sent here and which ones could be processed in country. So you can see in most countries a pathologist read is available, 86% of them. However, 33% of those, it takes longer than 1 month. So if you have a really sick patient, 1 month is probably not going to help you. We also did a lot of on-the-ground networking and training. This is really what goes a long way in developing programs like this. Personal communication, personal relationships, and developing trust is what has really built these networks over time. Here's an example of one of the cases that came through the internet-based site. This is a child from Lesotho. She had active pulmonary TB, but she also had these perfectly circular lesions on her thigh. And as a dermatologist, we see this and we know this is something called pityriasis rotunda. There's not many things in nature that come up so circular that you could draw it with a compass, and you can see how perfectly circular this is. This is actually the second case this person had sent me because he had recognized it the second time and just wanted to show me he knew what it was this time. And this is the process of learning that we see with teledermatology. And this child actually did well with 4-drug TB therapy, and these skin lesions cleared with her 4-drug TB therapy. Pityriasis rotunda is just a reaction to TB. This is cutaneous TB. It's also, this is actually active TB on the face. But it's another one of those recognizable things to me as a dermatologist. So once I teach someone about this, they'll recognize it the second time. This child cleared as well with 4-drug TB therapy. And this is one of those conditions where I can look at this child and say, that's a tumor and it's probably not very good, but without a biopsy, I can't tell you what kind of tumor it is or what the prognosis is. I need a piece of tissue. So they sent me a piece of tissue. This child was in Malawi, and although they do have a medical school there and possibility for processing of tissue, it takes a long time. And we didn't think this child with HIV and a low CD4 count had that kind of time. So she ended up having an EBV-related leiomyosarcoma, which is the second most common pediatric AIDS-related malignancy behind KS. And she did very well. This arose from the smooth muscle, probably in her skin. It usually comes from the GI smooth muscle. And she did well with an excision. And here's what the histology looked like. So that was our old experience, and we realized that with the rise of cellular networks, we could really reach a lot more people with transitioning to cell phone networks rather than the internet-based telemedicine. Although we could reach the people in the city centers where they could get on a computer, sometimes those computers were behind locked doors, or only the managers of hospitals had working computers. Excuse me. The cell phone networks really could get to rural areas and a lot more people. So overall, mHealth is defined as utilizing mobile communications for healthcare. We really utilize them for telemedicine, so making diagnoses and treatment decisions using mHealth. You'll hear Dr. Bennett talk about mHealth for many other things, and it really can be used for many things in healthcare. And here's some of those applications. You can use them to educate patients or providers. You can use them for helplines for patients. We use it for treatment, diagnostic and treatment support. They've been used for outbreaks and epidemic following, remote monitoring of patients, remote data collection, and following patients with HIV or even in different studies. And the way that mobile telemedicine works isn't that different from how regular telemedicine works, but just to demonstrate the flow of how it would work for a patient is a provider would have a cell phone with that application loaded on it, and a patient would come in, and they would open the application on the phone that would help them to gather the data. They would go through, the phone would have the application that helps them gather the clinical history. So it would prompt them for history that would help us make the diagnosis. And then they would be prompted to take photos, and they would press send, it would come to the physician, the specialist. That specialist would get an email or a text message that they had a case, and they would either log on to their smartphone or their tablet or their computer to look at the case, and they would answer the case and give their diagnosis, and then the provider would get some kind of alert on their phone that the case was answered, and they could open it up and see the answer. So it's independent of having to go on the computer. And when we first started doing this, people were hesitant to believe that patients would want you to pull out a phone and take pictures of them in the clinic. And so we did a study in Botswana using a bright pink cell phone, which we took pictures of patients' skin conditions, and the patients were overwhelmingly positive about this. Developing countries really passed us up in cell phone acceptance. They had over 1 cell phone per capita before we did. Phones were just spread like wildfire when the technology was out, and people were using it for everything. It was the first time they could communicate with each other anytime. We had landlines forever. People in developing countries didn't always have landlines, so when the cell phones came out, everyone had a cell phone. You may not have electricity, but you had a cell phone. You could charge it on the street. Someone would sell you electricity to charge it on the street. So everyone was accepting of the technology. And even in healthcare, if someone said, we can get you an opinion of a specialist using a cell phone, they said, wonderful. We had one person out of 120 that said, I'd rather not you take pictures of my face. So other than that, people were very accepting of the technology. We also did a study in Botswana that showed that cell phone teledermatology was reliable and valid. So also when this first came out, people were doubting that cell phones could do the same thing as regular camera-based, internet-based teledermatology. And that was because when we first thought of the idea that the cell phones hadn't quite caught up to what we have now. If you remember back to the iPhone 1 or the Google G1, they were sort of clunky, the pictures weren't that great, and now we have these beautiful pictures that are just like what we would take on any camera I would purchase from my clinic. But it showed that the concordance between the diagnosis we can get to on the mobile teledermatology is similar to what we would get to in person if done correctly. And in Botswana, it's a particularly difficult climate because it's the second highest prevalence of HIV in the world, so the patients have a lot of difficult skin conditions. They can be very sick. They may not be on any retroviral therapy. In Botswana, or in the US, we have about 5 doctors for 2,000 people. In Botswana, there's about 5 doctors for 12,500 people. And that country is considered a middle-income country for sub-Saharan Africa, so you can imagine what the lower resource countries in that part of the world look like. So this is what the mobile technology revolution looks like. Phone shops are everywhere. It's just beautiful entrepreneurial, whatever that word is, entrepreneurial culture. People are selling phones. They're, like I said, selling electricity to charge your phones. They're selling minutes. This guy down in the corner, you see all the used cell phones that people are selling. The old phones that people are just starting to buy their smartphones. And here's a few numbers for you. In 2003, 61% of the world's population was covered by a mobile signal. And in 2017, they predict that 85% will have more than a 3G signal, which will operate a smartphone. So that's insane. That's 14 years of increased coverage. And here's another interesting statistic. The percent of mobile devices owned by citizens in developing countries. In 2000, 25% were in developing countries of the 700 million phones. And in 2011, 76% were in developing countries. That's how big the market is in developing countries and how much they've embraced the technology. And this is also global device penetration per capita. You can see that the PC, which is the blue line, is sort of flattening out. And look at that slope of smartphones. It's crazy. And tablets is coming. if you look at the slope of the tablets and smartphones compared to the PC. So in Botswana, what we've done is worked with the Ministry of Health, University of Botswana, and a couple other organizations to create a sustainable mobile telemedicine program. We have worked with the government primarily to create telemedicine programs in visual specialties like oral medicine, cervical cancer screening, dermatology, and teleradiology. Recently, the government has taken over this program completely financially. They've hired local programmers who have a group, an international group that's also helping them. So it's a wonderful example of sustainability where a local programmer is doing the bulk of the work, but also has a phenomenal, globally recognized group working with them. We also have a program with the University of Botswana where we're bringing medical information resources to trainees using a tablet program. So the access to specialists that we're doing mostly triages patients from rural areas to the capital city using telemedicine. So if you're a patient in a district hospital and you need to have an oral surgery or you have a large oral tumor, they used to just send you down to the capital to be seen by the specialist. Now you can be seen by mobile telemedicine and they can determine, do you need to come down for a procedure? Do you need to have some tests first? They can triage you and have you come down when needed, maybe schedule an appointment, and it's a little better organized than it used to be. Here's an example of a couple tumors. The top tumor is a squamous cell carcinoma. The bottom tumor is Kaposi sarcoma. Related to HIV, but it really does help organize things a little bit better rather than just sending people down without notice. And then access to mobile resources. They have a medical school now, and trainees would, prior to our project, they would go out to rural areas and have no access to medical information, no books, no computers, and be practicing and learning and seeing patients, sometimes with no mentors. And now the University of Botswana has also financially taken over this project where each medical student and resident gets a tablet loaded with medical resources. The library there helps them load these resources on so that when they are away from the main hospital, they actually have point of care information to help them take care of patients. Here's a couple examples of things that are loaded on the tablets. And phone users are faculty, residents, and students. And you can see how it's grown over the years. It started with us just trying this out with 7 of the medicine residents in 2010. And we're actually, in 2014, we're up to about 320 users. And I heard the other day UB just bought, I think, 80 more tablets. They used to buy laptops for all their students, and they transitioned it now to 7-inch tablets. And here are the trainings that the library does for all of their users. We're not even involved anymore in these trainings, which is beautiful for us to see them taking over these projects. And then the last thing I'm going to talk about is telepathology. At the National Lab, we have someone in the audience that may be seeing this firsthand, but we installed this live telepathology system at the National Lab, so I can actually read pathology from my office. I can actually move the scope that's in Botswana and read it, take photos, and help them with cases that they need help with from their skin clinic. This is Dr. Kayembe, the pathologist there. And in order to institute this somewhere, you actually have to have someone like him who reads pathology and needs help. You need internet that's adequate. You can't just put this anywhere. You need a playing field that has a few things, and this is another resource that helps them. And this is just an example. This is a patient who's HIV positive and has these new umbilicated papules and ulcers on her face and body. And this is a picture I actually took from my office of you can see most of you are not probably dermatologists or dermatopathologists, but in the dermis, there's all these little round things. This is cryptococcus in a HIV positive patient, and we wrote this picture, not too bad, take it across the Atlantic Ocean, I thought, on my microscope. So I was able to help them with the diagnosis. And that's it. Thank you.